So without any further ado, let's go ahead and just get a general introduction of our panel. Dr. Gritter, she's a nephrologist, so this is going to be a very interesting story, I feel like. She's in North Carolina and with a soon to be appointed with the Wake Forest Enterprise Health System Primary Care Sports Medicine. He's also a team physician, for the Carolina Panthers in the NFL and a member of the NFL General Medical Committee. Dr. Liddle is a team physician for Utah State University and is affiliated with Intermountain Sports Medicine as well as Logan Regional Orthopedics. Dr. Rizzone resides in Rochester, New York, and is an assistant professor of orthopedics, rehabilitation, and pediatrics. He's an associate program director for URMC's Family Medicine, Primary Care Sports Medicine Fellowship, and head team physician for the SUNY Brockport and University of Rochester. And Dr. Senter is in San Francisco, California, and is a team physician for the University of San Francisco and Washington High School. Her research is in educational interventions for medical students, residents, and fellow clinicians to help them better understand the musculoskeletal system. And last but not least is Dr. Dixit, and I must admit that I do not have much information on you, Dr. Dixit. So why don't we start with you and introduce yourself and kind of give us a background of your story. Oh, you're muted right now.
Yeah, sure.
Perfect.
So my story is that I was born and raised in Baltimore, Maryland. I went to the University of Pennsylvania and majored in bioengineering as an undergrad, and then I went to Maryland for medical school, University of Maryland, which is in Baltimore. And I think how I chose sports medicine was between my first and second year. We had one of those programs that I think a lot of medical schools have, where we did research they match you up with the faculty to do research. And I was doing, I was interested in sports medicine. Perhaps at that time, early on, this is probably going to be a common theme. I had some interest, I think, in orthopedics, which is what I thought sports medicine was. But through that research, and maybe this was a little bit earlier than most people make this decision, I worked with a physiatrist at Johns Hopkins named Tamara Lauder, and we did research in the female athlete triad in female military recruits at the time. And she's the one who kind of said, look, if you want to do surgery, this is what surgeons do. They do surgery. With athletes, most of the musculoskeletal care doesn't require surgery. And a lot of what happens in athletes is all these other things that we all know of. And so I really, for a while in medical school, was kind of focused on physiatry. And I think, I've been thinking, I looked at the sort of the questions ahead of time. How did I choose internal medicine? I think I was sort of pretty interested in a lot of the different ways to get here. I think you sort of eliminate things along the way based on what you don't want to do in residency to a certain extent. So I think I was very close. I switched from physiatry because I really enjoyed internal medicine and peds, and I was very close to doing med peds. And then just sort of the bias I had at my institution was a lot of the med peds folks had told me, you're going to choose one or the other and subspecialize. And I don't think that's necessarily true, but it was true at that institution where I was training. So I kind of, I liked, when I think I might be the oldest person on here, I'm not sure. But when I went into sports medicine, it was more of a sort of an unknown quantity. And I think I probably liked the flexibility you had coming out of internal medicine and the approach of internists and how they think. And so I think, while I was confident this is what I was going to do, I think I liked the idea of having other options if it didn't work out. So maybe to a certain extent, that was part of my reasoning at that time. And then I think as I sort of went through everything, I think my approach was really more like an internist. And so I did my residency at Northwestern in Chicago, where I had a few mentors that were internists. I mean, at the time, there really weren't that many who had done sports medicine. Greg Ewert, who ran coverage, who's in private practice in Chicago and ran coverage for the Chicago Marathon. And then two folks that had done fellowship out of my residency, Balu Natarajan and Bob Strugala, helped to sort of guide me through the process as an internal medicine resident, which was very helpful. I did my fellowship at UCLA, and for me, it was a really good fit because it was a 2-year fellowship, and I thought I needed more exposure to sort of the day-to-day nuts and bolts, which I think a lot of our family medicine colleagues get during residency. I didn't have that. And then I was mentored by really strong family medicine, sports medicine faculty. We're in the home stretch now. Subsequent to that, I worked at Cal Berkeley, the lady who now works with Carlin, Cindy Chang. And I think that was my sort of first, we worked out of student health at University of California, Berkeley. And that was my first exposure to sort of just a ton of exposure to being in charge of team coverage, team position coverage. And I loved it. I was there for 3 years, but then I had an opportunity to come back to my hometown in Baltimore at Johns Hopkins. And I took that. And I was there for 10 years. I never thought I'd leave. Told my wife when she moved there, you know, my family's here, I'm not leaving. And then this is why it's confusing. So why you didn't have my background. I'm sure when you Google me, it's all sorts of stuff. But I'm now at the Hospital for Special Surgery in New York City. And I came here for the opportunity to be in an academic environment in primary care sports medicine. We have 17 primary care sports medicine faculty, all of whom are really strong. I'm an associate program director for our fellowship here. There's just a lot of opportunity for sports medicine here in terms of the whole breadth of what we do, education, research, and other things. My day-to-day, it's hard for me to say what my day-to-day is because I started here in January, and 6 weeks after I started here, a pandemic started. So I would say I'm primarily non-surgical sports medicine out of an orthopedic practice. I work out of a sports medicine clinic. I do team coverage with US Lacrosse as well as New York Knicks right now. That sort of takes up some of my time as well. During the pandemic, we had urgent centers for orthopedic injuries to sort of offload the emergency rooms. And I worked in that. We actually, as an orthopedic hospital, took care of COVID patients. I didn't do that personally, but my colleagues in primary care sports medicine, many of them did. And so that's sort of our pandemic experience. So I know that's sort of a long-winded answer, but that's my answer.
No, not at all. Thank you for sharing. Let's go on to Dr. Gritter. If you would mind giving an introduction about yourself, your nephrology background, and how you kind of found and sports medicine and the NFL and all that stuff.
Sure. And Samir, I don't think you're the oldest on the panel. So so my name's Nancy Gritter. I'm here in Charlotte, North Carolina. I am internal medicine and nephrology boarded, as well as primary care sports medicine. I'm originally from Indiana. I went to DePaul University and as many on the panel was an athlete throughout high school and college, attended Indiana University Medical School, and then went on to Vanderbilt University to do internal medicine. I graduated from medical school in 1992. So, you know, my experience is in making that selection of doing internal medicine. I actually thought I was going to be an orthopedist and did research in that area, and then you know, had this realization of being at a family reunion or something, and someone coming up, well, I thought you were going to be a doctor. No, I'm just a big toe specialist, or I just do this procedure, and realized that my real calling was internal medicine. The types of problems, complex medical illnesses, the differential diagnosis. I mean, that's how I was geared. So I did internal medicine at Vanderbilt, very traditional place. Primary care sports medicine was not even a subspecialty when I went through my training. And I did internal medicine chief residency at Vanderbilt. And again, my influence then was my mentors there, which we may have similar mentors with other members on the panel, but I went into nephrology, the types of complexity of questions and the issues that we addressed, from glomerular disease to acute renal failure, supporting with renal replacement therapy. So I became a nephrologist and joined my practice here in Charlotte 22 years ago. And so I've been a practicing nephrologist for 20 years and continue to this day. How did I get to sports medicine? Back in 2006, the primary internist for the Carolina Panthers. There was a player who had protein in his urine during his pre-participation physical. So my initial contact with the Carolina Panthers was consultation for proteinuria. Managed that patient through the season, biopsied him after the season. Here was a 26-year-old with membranous glomerulonephritis. So rare enough to have a glomerular disease, but then subsequently rare to have membranous glomerulonephritis. So managed that patient through, he became vested in the NFL, but then had an untoward complication of membranous, had a pulmonary embolism with a pulmonary infarct. There were no novel oral anticoagulants at that time. He was on warfarin, so his career was over. But that was my hook. In medicine, I think it's all about the relationships. So that was my hook with the medical staff, with the Panthers, within our community, sports community in Charlotte. So I became kind of the go-to consultant in terms of areas that were already my specialty: hypertension management, exertional rhabdo, exertional hyponatremia. So I was practicing that clinical practice. But then the team physicians with the Panthers approached me about becoming their general internist when the current physician retired. So that's what I was working towards. And then a little thing called the collective bargaining agreement, NFL, with the Players Association, mandated that anyone that is a head team physician, if you're already not grandfathered in, anyone, a head team physician, either orthopedist or internal medicine or medical physician, needed to be board certified in primary care sports. So then it was looking at that. Okay, how committed am I to doing this? So can you show clinical experience and sit for the board certification exam? That wasn't an option. And so I pursued doing a primary care sports medicine fellowship as a PGY 23. So in 2016, I did a fellowship. Mine was over 2 years. It was a 1-year fellowship through Atrium Health, the family medicine department, but I did it over 2 years because I didn't leave my day job. So I cut back from my primary responsibility with my group as a nephrologist. And so over 2 years' time, did the primary care sports fellowship, completed in 2018, took my boards, and then transitioned to the primary head team physician, internal medicine physician with the Carolina Panthers, and then still have maintained a medicine practice, sports medicine practice. But my primary practice is more with the medical issues for novice athletes, weekend warriors, high school, college, professional athletes. Using my expertise as an internist nephrologist, more so than doing non-operative procedural musculoskeletal sports medicine. I do some of that, but primarily I'm still an internist at heart. So that's how I came to this panel.
That's pretty incredible. Definitely appreciate that. Dr. Liddle, would you like to follow that? Or Liddle? Dr. Liddle, Liddle?
I would not like to follow that. I don't want to follow that at all. Mine's like the most boring story ever. It was boring before, and now by comparison, it'll be like watching lettuce wilt. I picked internal medicine because I love taking care of the whole patient. I love structure and function, so sports medicine made perfect sense. With 85% of sports medicine and even the orthopedic side being non-operative, it was a pretty natural fit. I think people assumed I was either going to be a surgeon or a radiologist because I was kind of an anatomy and physiology geek. Radiology's fine, but I was actually thinking about this earlier today. I was thinking, how bored would I be making cool diagnoses without actually being able to show it to the patient and explain why it's going to happen and explain why, you know, well, we got to keep your hand at neutral so that your fracture doesn't shorten and due to the tension of the flexor and extensor tendons and like all these things. And as a radiologist, I would just go, well, yep, it's broken. It's comminuted proximal phalanx fracture. Good luck, next. And then as a surgeon, I mean, I just, the OR is very seductive. There's all this kind of pomp and circumstance in the garb, and you got to wash your fingernails in a certain way and gown and glove, and people bring you things to put your hand into. It just, it was cool. I love the procedures of it all, but I didn't love the OR more than anywhere else. The surgeons I knew who were happy would have rather been in the OR than anywhere. And I could not say yes to that. That was not what I wanted to do. And I was on my surgery rotation at the VA, and I was thinking, oh, this is great. I'm going to be a surgeon. I'm going to do this stuff. And I the procedures and the anatomy, sure, but the interactions with patients were not rewarding. I was in a surgery clinic, and this guy had a lipoma on his back. Simple 5-minute H&P for the average general surgeon. And I was in there, and you know, you can't tell by this answer, I'm not exactly, the brevity is not my strong point. Levity maybe, but not brevity. I was in there for like 15, 20 minutes because I was taking his smoking history, and I was talking to him about all of his, you know, peripheral neuropathy and his knee pain and, you know, all this other stuff. And I'm like, well, why does this bother you? Well, he's a long haul trucker, and it rubs on his seat, and it bothers him, and it's causing pain and functional problems and all this other stuff. And I walked out, and all the surgeons are like, dude, where have you been? Like, we got stuff to do. And I'm like, I was talking to the patient, like, he needs a colonoscopy, he needs this, he needs that. And they're like, that is not, like, lipoma, cut, no cut, move on. Okay, well, maybe my personality is not meant for general surgery or orthopedic surgery. And so I figured I'd go into family medicine because that's the only way you can go into sports medicine. At least that's what I understood at the time. And there's nothing wrong with family medicine, except you have to do OB. And you have to train like 9 years of training in 3 years. I mean, I think the med peds people were nuts to try and do 6 years in 4. No offense, Katie, or would have been Samir. But that's just a lot of training. And if you don't love it all, why do it all? And what I really loved was complex medical problems, helping people with medical issues, simple or complex, that affect their life and their quality of life. And yet I loved the structure and the function. And I was on my sub-I in family medicine, and I had my friend who was on his sub-I in the unit at the VA, and Amy Powell was attending on the wards. And he said, hey, my attending's an internist and does sports medicine. And I'm like, what? You can do that? And he's like, well, she does. And so I talked to Amy, and she was kind enough to take a schmuck and mentor him, and, you know, guided me through it all. And, you know, pretty soon I'm interviewing at all these places, and was blessed to go to Vanderbilt for my fellowship. I did med school at the University of Utah, and then did internal medicine there as well. And, you know, had nothing but great mentors there, from rheumatologists to internal medicine doctors to sports medicine docs. But at one time I was in the shock trauma unit, and we were taking care of all these spine cases for ortho. And I thought, maybe I could do sports medicine as a day job, and then just do like a week in the unit. And because I loved critical care medicine, and I love shock, and I love all this stuff. And then I was like, nope, don't want to be the hospitalist PA for an orthopedic spine specialist. Not interested. And I realized how dumb of an idea it would be to do sports medicine, which this great breadth of medical and surgical issues and all this other stuff, and then be in the unit part of the time, and like give up all of the great things about sports medicine and work-life balance and exposure to things outside of medicine. it was a fleeting thought. I was in the unit. I was sleep deprived. I moved on. But I actually did look up fellowships. You can actually do it. So I got to Vanderbilt, and they have a unique model where you do a 1-year fellowship, but a 2-year commitment. And in the second year, you essentially work part-time as an attending, and then the other half of your time you spend working with subspecialists in orthopedics, so joints and hand and foot and ankle and all these other kind of exposure to subspecialists that you don't get in the average fellowship, which was a great fit. And the group was very balanced. It had this great combination of surgeons and non-surgeons and 9 primary care sports people and 3 surgeons, and you just got this great exposure to learning to think like the surgeons think and think about how they'd approach those problems, and at the same time how the non-surgeons do it. And it's a very academic place where, look, you better know the level of evidence that you're basing your decisions off of, otherwise you're going to have to answer for why you don't know the level of evidence. And recognizing that evidence-based medicine doesn't tell you everything. Like, evidence-based medicine teaches you how to treat the average patient. It doesn't teach you how to treat the individual. And that balance between psychosocial medicine and evidence-based medicine was perfect for an internist or med peds. And then there's a lot of smart doctors from every background in evidence-based medicine. But I think, you know, the whole Choose Wisely campaign and ACP, they just really kind of push that idea, and all the subspecialties in internal medicine really push this idea of evidence-based approach. And just the way you think through problems and the way you think about the whole person and you put it in context, it was a perfect match for my personality and how I like to approach people. And I stayed on as faculty at Vanderbilt and worked there for 9 years, the last 4 of which I was the program director. I got to work with great people like Katherine Rizzone and other people on this committee who've taken the same training and done far more with it than I have. And then about a year and a half ago, we had some kind of medical issues come up in our family and needed to get out of the South with their humid pollen bowl that is Nashville, and was lucky enough to come to Intermountain Sports Medicine and become a team physician for all the Olympic sports at Utah State. My time at Vanderbilt, you get to cover both Belmont University and Vanderbilt. So you get to see kind of SEC and then a mid-major school and the differences in the programs. And then I was also the team physician for the minor league baseball team there. And most of my time was spent in baseball when I was in Nashville. And now here I get to, oh, there's a athletic trainer from the university calling. Here I get to take care of gymnasts and runners and female athlete triad and primary amenorrhea or secondary amenorrhea and that whole workup. And I haven't thought about those things in a long time. So it really makes you dust off the cobwebs of your internal medicine background to do all that stuff. So it's been a great fit for me, and that ability to, about 30% of my practice now is general medicine for athletes and or the coaches' wives who came in with a WPW ablation and now having PVCs in the setting of COVID-induced anxiety. So that was, my staff was wondering why I was seeing ankle sprains and fractures, and now all of a sudden I'm doing a cardiology workup. But that's what you do when you're an internist and you do sports medicine. You do a little bit of everything. You can make almost anybody better somehow. So that's just what you do.
Dr. Liddle, that was equally entertaining. Dr. Rizzone, would you like to go from there?
Hey, I'm Katherine Rizzone. I'm at the University of Rochester in New York. I was born and raised in Buffalo, New York, so just down the thruway. I went to the University at Buffalo. I was an athlete there. Then I actually taught high school science and coached for a few years. Went to med school at Chapel Hill in North Carolina. And then also ended up at Vanderbilt, did actually medicine pediatrics there. So I think you folks were interested in hearing it from that aspect, to have the peds. I really did not know when I entered med school. I was very impressed with Sam's early epiphany of what he was doing, of what I was going to do. I think the med peds choice reflects that, because you really don't have to make a decision. So I had taught high school. I had worked with adolescents, so I really was thinking of doing like family med and then doing adolescent med. But similar to what some of the folks have expressed here, I really liked, not that I don't want people to be sick, but I really liked being in the unit. I thought, you know, and again, family medicine is an excellent training ground to do sports med and so many other specialties. But I really wanted to get, I really wanted to be an internist. I really wanted to be a pediatrician. I wanted that full 2 years of each, and similar to what Dr. Liddle referred to, you know, again, family medicine I think is awesome training. I mean, the vast majority of people who are sports med docs are family med trained. But I just wanted to have a little bit more. And so for me, it was a good choice, just because I knew I'd get that in-depth information. And, you know, being an internist, I had always thought I would be a big P little M. Like I thought I liked the peds more, but then when I did med peds, I really ended up being a big M, strong big M, and a little P. So I'm really happy I chose med peds over just peds. When at Vanderbilt, so I think I might know who Dr. Gritter was, who her mentor was, with all the strong nephrologists there. And so just a great program. And by the time I got there, because Dr. Liddle was there at the time, there was a great orthopedic department period, but also a very strong primary care sports medicine presence. And I think that's something to think about as people look at fellowships, you know, depending on who's listening to this, where they are in their pathway. It's just, I was raised in an atmosphere where there was way more primary care sports docs than there were the orthopedic surgeons. I mean, I think it's important to have a balance of both, obviously, but how I grew up in sports med was very much that our voices were very respected, very involved. We did a lot, we basically did everything together, you know, with conferences and stuff. So I think that's an important thing to consider as people are moving through, you know, just as you train or where you work, you know, to have that nice balance with the surgeons. It is, and I don't know what fellowships are going to do. It looks like they may end up going to 2 years anyways over the next couple of years, but it was a 2-year fellowship actually through PEDS when I did it. So they accept a lot of different people, including internists like Dr. Liddle. And rather than doing what Dave did the second year, which was a smattering, which I think is great, of kind of more in-depth subspecialty stuff within orthopedics, the fellowship director at the time, Andrew Gregory, who was fantastic, and Kurt Spindler, who was leading the division, okayed for me to go and get a master's in public health. And so I got a master's in public health. My rather than a 2-year fellowship, it was a 3-year fellowship. My wife was not happy about that, but it ended up working out, I think. And I did it through the Quality Scholars Program at the VA. And one of the reasons I had chosen to do residency at Vanderbilt is I really wanted to train someplace where there was a VA. I just really, you know, felt strongly about it. And I just think it's an excellent training. It's a great institution to work for. I mean, they also value primary care sports docs and orthopedic training background. So that was a great way to get a much better understanding of research and start a research program. And again, I mean, that was, you know, through the VA institution. So they have opportunities, you know, if people are thinking about training through that, or if that's something you're considering, you know, just based off of the med school you're at, a residency that you're considering, it's something to keep in mind. And then just at that point, I was born and raised in New York. I have 3 kids. So wanted to head back home, you know, closer to family. So accepted a job at the University of Rochester Medical Center, which for a small city has a very strong orthopedics program. So have, you know, in terms of the day of my daily life, I do not do primary care anymore in terms of like, I don't have a medicine or pediatrics clinic. I do a lot of primary care as the team doc for 2D3 teams. So see a lot of that in my training room. But when I'm in clinic during the day, it's pretty much, you know, sports injuries. I mean, I think I see pretty similar to what folks have mentioned here. You know, just something to consider as you think about career stuff, like, you know, just kind of coordinating off different areas of clinics. So I have a runner's clinic where just runners, you know, get spots. So the schedulers understand that just runners can go in those spots. So we have kind of carved out that as a niche. In North Carolina and in Tennessee, physical therapists can do something called dry needling, which is not acupuncture, but it's a different type of modality. And in New York, unfortunately, they cannot. So when I got certified in that, it's not hard to get certified. But that's something I have, like a dry needling clinic as well. And I think that's helpful for a lot of adults and, spasm muscles, and things like that aren't getting better with PT or trigger point injections. More recently, in the past couple years, I started doing radiofrequency ablation for knee arthritis. So, obviously that's primarily an adult issue. And that's been really fun because I've always liked procedures. I do a lot of ultrasound guided procedures in clinic, but then added that as well. And so have a lot of procedure room time. I had not even heard about that in fellowship. And it's a great kind of middle ground in between, doing cortisone and viscosupplementation, and then actually, people going for a total knee replacement. So I've added that to my clinic. And then, like I said, I'm a team doc, and then I do research as well. So I don't want to take too much time, but try to get a full smattering and then keep a lot of procedure time in there, because that's something I really enjoy.
Awesome. Thank you, Dr. Rizzone. And last but not certainly least, Dr. Senter.
All right, thanks. It's great to be here. It's really fun to hear about everyone's background. So I'm Carlin Senter, and I grew up here where I am, which is the Bay Area, in a little town called Piedmont, which is in the middle of Oakland, across the bay from San Francisco. Went to college at Harvard, and I was a rower there. I was a Radcliffe rower. And I think, that's where I developed a love for the science of exercise, really. I think when you do sports like that, the more you understand about science, kind of the better you can be at, not having enormous personal athletic ability. I think you have to sort of harness other skills and figuring out, how to train properly and how to keep yourself free of injury and all that. So I finished college, went home, and actually taught high school, coached a little bit, crew, and then went to UCLA for medical school, which was really fortunate. I think when, it's interesting when you think back about these things, how your career develops, and it just was really lucky that I was there, where there obviously is a strong primary care sports medicine crew. And my mentor was Dr. Hack Suzanne, who's now at Minnesota. And so I was just really lucky that as an early med student, I was, really inspired by her work in her clinic, and eventually decided, though she's family medicine, decided that internal medicine, I think, was for me, mostly because I really like taking care of adults. And then as I went to UW, again, fortunately they have a strong family medicine, sports medicine program. They also have, I really enjoyed my time as an internal medicine resident there. They have a huge internal medicine program, training across 3 hospitals. And kind of like Katie said, I've always valued the ability to train in different places, like a county, a VA, a university hospital. And I think for trainees, that's always been something I've really valued, because then you get a chance to see, even here, also being able to go to something like Kaiser, you get a chance to kind of get a sense of, where you see yourself. And so that was something I really liked about being at UW. They also had a lot of flexibility in the residency, which allowed me to do a couple sports medicine rotations. So I was very fortunate to be able to do that as a resident. And that really solidified my interest. I matched as a fellow at UCLA and did a 2-year program there. I did a med ed fellowship in addition to the sports medicine fellowship. And so have been able to do some med ed research. And that's my main, I'm a clinician educator now at UCSF. I've been here since, this is my 11th year here. I've been here ever since I finished fellowship. And UCSF being University of California, San Francisco. And my, really what I am is a clinician educator. So I would say big C, little e, in terms of I see a lot of patients. I have a smallish primary care practice of about 300 patients. So on Thursdays, I'm a primary care internist, and the rest of the time I'm a sports medicine consultant. And my sports medicine practice, I'm newly appointed the director of sports medicine here at UC, and of primary care sports. And thanks. So taking on kind of a new leadership role and direct the concussion program, and have been busy this year being the program planning chair for the AMSSM 2021 meeting. That's been a big project, which many of you have helped with. So thank you, thank you. And yeah, that's sort of what I do and what I've done.
Definitely going places. That's awesome. So one thing that's kind of been, I thought, kind of interesting from our fellow talks on A Day in the Life of is kind of a lot of physicians kind of started out thinking that sports medicine was orthopedics. They get into orthopedics and they're like, I hate that OR. And then they kind of find something else. And so some of it was emergency medicine or family medicine. You guys chose internal medicine. And it seems like it's kind of been the complexity of the cases and things like that that kind of drive you into internal medicine. So what kind of, if you were a medical student at this point and you were looking at internal medicine programs, you kind of maybe have a thought that you want to do sports medicine in the future, kind of what would you be looking for in an internal medicine program that would kind of lead you down towards that path?
I can take a shot at this. It's a good question. I think I tend to be altruistic. So there's two ways you can be. You can be altruistic or you can be sort of practical about it. And I think you want to go for the best fit for you and your education, because ultimately, I think if you look at sort of everyone on this panel, that's sort of how we all end up where we are, is we just kind of did what we wanted to do and what we were interested in. And if you kind of chase that, I think that's, certainly you can find a program where they have a strong sports medicine presence and kind of gear up for the next step. And that there's nothing wrong with doing that. And a lot of people do that, in all the specialties. But I think I really tend to come at it from of what's the best fit for your education. I mean, you heard both Carlin and Katie talk about sort of different training environments. And I think that's probably more an internal medicine thing than the other subspecialties. We desire to be in VAs. We desire to be in private settings. We desire sort of the whole breadth, because there's a lot of different ways to approach medicine, and we learn from that. So I think if that's the way you think, then internal medicine is a good fit. And then I think finding the thing with internal medicine is there's so many programs, you can always find a fit. So I think that'd be my answer.
Thank you.
I think the other thing I'd add, because I totally agree with everything Sam said. I loved, and I also agree with the idea of being able to train in multiple places. There are so many ways in this world to make money. And if you don't love medicine, don't do medicine, because there's plenty of easier ways in the world to make money. Now it's all trade-offs, right? But I think the same thing is true when you pick a subspecialty. Like, so I was shadowing a cardiologist once, and we were going to go in and do an AFib cardioversion, and he just kind of, we'd done multiple things that day, and I was like, wow, this is really cool. And you're doing caths, and you're doing this, and you're doing that. And I'm like, whoa, we're going to put this person to sleep and like shock them with electricity and just hope that their heart restarts in the right rhythm. And I'm like, this is amazing. And he's like, it is the low back pain of cardiology. He's like, you have to understand every medical specialty has a low back pain. Now, ours actually is low back pain, but I think that the idea was saying, look, if you don't love, you can love scopes and you can love hepatology and you can love how the liver works and you can do it. But if you don't love like squirting out somebody's colon in order to see if they have polyps, you probably, and you can't handle the sights and sounds and smells of gastroenterology, you probably should not do that, because you're going to spend the majority of your time doing that. Like if you can't, one thing I really liked about internal medicine is that, there were so many options that if I realized, gosh, the words and the sound of pulmonary toilet is just like dealing with lung butter all day, every day, and the sound of the vent going off. Like I realized, look, as cool as critical care medicine is, I just cannot deal with that the rest of my career. okay, well then scratch that one off the list and you move on, and you can, and I just think that knowing what you like and what you don't like and doing what you love, there's lots of ways to get there. And internists are the minority of sports medicine docs. But I think that their training and their logic and the way they think and the way they approach a patient can help anybody anywhere. And if that's the way your brain works, then do the thing you love. Because there are plenty of ways to get to where you really want to be. And look at Dr. Gritter's background, for crying out loud. She took almost every path and got exactly where she wanted.
I was waiting for the nephrology joke, you know.
I thought about it, but you know, I actually like nephrology, all the lines, and you know, got to respect the beans.
I think I'll just, you know, if you're looking at it from a med student perspective, I just want to make 2 points. And I don't want to be biased towards large academic centers. I think that's where a lot of us train, and it doesn't mean that you have to be. I mean, I think there's so many different types of med school setups and residency trainings that are at community hospitals that are like needed and awesome and actually great training experiences. If you're not sure, if you land in a large academic med school, you are going to have the opportunity to change your mind multiple times and probably land okay. And so again, I'm not saying you have to go that route, but even if you're sure of what you're going to do, it's kind of nice to be in that environment, because all of a sudden, just by happenstance, you'll meet people and you're like, well, they're actually doing what I really want to do, but I didn't even know that that person existed. Like, I think you guys, you know, might have heard that throughout this, is that some of it, this is just, you know, serendipity that we happen upon these paths. The second thing, and this is hard to, you know, this isn't going to age well, but in this time of COVID, as an associate program director in fellowship, it's been really tough. We can't take, you know, rotating medical students. We can't take residents from outside programs. Rightfully so, I understand all that. So if you're in, you know, towards the end of med school, or I don't know, you're kind of further along, like if you can, again, be in a place with a large academic center so that you can rotate with a lot of different people right there, it is something to at least consider in these times. Again, I hope this ages poorly, because I hope everything is going to return to close to what it was before. But those are two things that take into consideration, I would say, especially if people aren't exactly sure, which is okay. Again, I'm the med peds person, what they want to do.
One more thing I was going to ask you, Dr. Rizzone, was the benefits of training at a VA. Both you and Dr. Senter kind of brought that up, and I was wondering maybe if you touched a little bit more on that.
I mean, I think it depends. Each one is so different. That's what's so cool about the VA, is that each one has different strengths and really different specialties. The one in Nashville, the Tennessee Valley one, they just, overall, they had a pretty strong orthopedics program, but at the same time, it was very primary care focused in terms of how they approach stuff. So yes, the orthopedic surgeons did surgery, but they were also still primarily focused on the fact that most of it was non-operative care that was needed. So as far as I know, I don't know of any specialized fellowship at the VA, but certainly there's people. I mean, there was a resident who Dr. Liddle mentored who went through residency at Vanderbilt, did fellowship elsewhere, and I believe he's still working at in the VA system, doing non-operative sports care. So it's totally. I mean, think about just in terms of the younger veterans of who's coming through. There's been unfortunately a lot of recent conflicts. So a lot of these vets are in their 30s and 40s and 50s, and many of them are very active. So that's something that's really needed in the primary care system at the VA. And again, it's a really, I mean, it's rewarding work in so many different environments, but I just found it to be very rewarding.
Awesome, thank you. Now let's kind of change perspective into like a resident's eyes, and you're already in your internal medicine program and you're going through residency and you're kind of eyeing out sports medicine. You weren't quite sure of it before getting in residency. Now you're kind of eyeing it out. It's COVID times. Kind of how do you set yourself up for that fellowship?
Can I maybe dovetail off that question and still put in a plug for the last ones?
Yeah,
I think it's important to not believe the things that most of us were told, which is you can't do sports medicine through internal medicine. Like you just can't get there. There are only like 4 programs that'll take you in the whole country, and that's not true. Now, because I remember sitting down as an intern, and Katie will laugh at me, but I sat down and I was like, okay, you told me that's what it is. Let me find these fellowships. And I went to AMSSM's website and I clicked through them and I went through all 130 programs, and I had the spreadsheet and I had the whole thing. And who do they accept and who do they not, and all this other stuff. Like 88 out of 130 fellowships take applications from internists. Like very few were like family medicine only, pediatrics only, PM&R only. And that's fine. Like there's no problem with a fellowship deciding who they want to take, most of which is unfortunately decided by money and politics, not by the applicant's worth or value. Because every primary care background brings something unique to the table. Like I love my physiatry friends. They're my partners and my colleagues at Vanderbilt and my friends around the country. Like they just think about things differently than internists do. And my family medicine people do the same thing. Like everybody brings something to the table. And the reality is you can get into it from any background. So, but I'll then put my fellowship director hat on and say, well, if you want to get into fellowship, and God, I'm so glad I don't wear that hat full time anymore. Is just, no, sorry for those of you that do. I think that the ability to, you also have to recognize that if you're going to go into it from a non-traditional field, which is pretty much anything other than family medicine, if you're going to be the exception, you got to be exceptional. Like you have to recognize that you are different, and that's okay, but have an answer for why. Well, why'd you choose this? If you knew you wanted to do sports, why did you choose this atypical pathway? People just want a real answer. You don't have to defend yourself. You don't have to feel defensive. You don't have to make up excuses. You just have to say, look, I didn't love OB. I didn't love surgery. Like I didn't do those things. I love taking care of the whole person. I like dealing with adults and or kids. I like complex medical problems, and I love musculoskeletal medicine. So it was easy enough to do. Like you have an answer for those questions. And then if you're getting ready for fellowship, the advice that I got from my mentor was you can't have gaps. Like download the application, know what they're going to look for. You need to have something in every spot. Now you need to excel in something. Which for me was hard because I don't excel easily. But I think making sure that I didn't have gaps. When I read people's applications and they've done like one research project during their undergrad year and they haven't touched it since, that's a gap. When they haven't done any team work and they haven't been on the sidelines. Well, how do you know the job if you haven't been out there with the people who do the job? You know, being a former athlete, it's a little bit like graduating from a pediatric-based fellowship, and being a dad and being a doc does not make me a pediatrician. I'm not. Like, you want me to take care of their bones and joints, I'm fine. But if you bring me other stuff, you better talk to some other people on this panel, because that's just not what I did. And that's okay. Knowing what your strengths are and knowing what you're interested in is totally defensible. But I would make sure that you don't have gaps on your application. Make sure that something is in each of those boxes, and find something that you love and excel at it. And that's what's going to set you apart. If you're different, different's okay. The good fellowships just want the best people. And the fellowships that can't take the best people because of their funding or their chair's preferences, that's okay. They'll get good people. It just doesn't have to be you. You can only do one anyway, or at least only one sports medicine fellowship.
Thank you very much. Anyone else want to tackle that one question?
You know, I think I've been really impressed locally with what our med students and residents have been up to. Some of them with more free time than others because of COVID, and just doing some really wonderful community-based interventions. We had a bunch of med students hold a blood drive early in COVID because that was needed in the community. You know, volunteering to reach out to patients and just do important public health work. And so I think, is that sports medicine? Not traditionally. I think as an internist, so my mantra is every patient is an athlete, which is because I strongly believe, as probably many of you do, that, you know, exercise is medicine. And that's why, you know, I love being an internist and I love practicing sports medicine. And so in that, it's sort of like, all right, you know, we're in this hard time. What do our patients need? And what can we do to help them be a bit more active, be a bit healthier in this tough environment? So, and I know a bunch of AMSSM members too have been doing just really cool online exercise programs and creative community outreach stuff during this. So that kind of stuff I think has really impressed me during this period of time to hear about that stuff.
Thank you. All right. Well, we have about 7 more minutes here, and kind of maybe some closing thoughts from each of you. Kind of what makes like the internal medicine, sports medicine kind of path the best for you? Like, kind of sell somebody on internal medicine, sports medicine.
I'll let Katie go.
Okay, sorry, Sam. I think for me, COVID's really highlighted it. I mean, I did a ton of cardiology rotations, and again, I still think all the other training pathways, PM&R, FailyMed, ED, all that is really helpful when you are seeing an athlete in training room or in clinic. But in terms of this return to play post-COVID, I mean, we see a lot of EKGs in internal medicine residency training. So I never expected it to you know, pan out like this, but I'm very comfortable with all these recommendations and like what to do next and what this means and these studies. I mean, again, I had CVICU. I think most of us, you know, had multiple cardiology rotations, CVICU. We took care of some really sick patients that I feel very comfortable having these discussions with families and with colleagues, and have gotten involved with some of the leadership stuff there, because just my training has really enabled me to feel comfortable with that. It's terrible, obviously, but the reality is that that's also how we serve our patients. And unfortunately, it's not just COVID. I mean, it's mono, it's rhabdo. I mean, Dr. Gritter is a great NFL physician, non-traditionally, because of her background training of that. I mean, those guys are working at a very high level under a lot of stress in their bodies. And so things break down. I don't know who's better than a nephrologist to understand all that. So I just feel like the in-depth training of pretty sick patients, even though most of your athletes are going to be okay, it's just stuff happens over break, stuff happens, you know, outside of sports, but then they're still your athlete. And then you're going to feel very comfortable taking care of them.
Very good answer.
I think the other thing with internal medicine is, you know, as we trained, we develop, there's a differential diagnosis. You don't come in and go, gosh, that's just a bone bruise. You know, we go to meet, oh gosh, is this a bone tumor? Is this, you know, I think it's just innate within us. So I think your selection of your, you know, coming out of medical school, that's your first decision point. I think you've heard it on this panel. We all innate within us are internists. We're internist geeks, nerds, I think. But that's the training we went into. And maybe it's because we couldn't make a decision, right? You do your cardiology rotation, you like that. You did nephrology, you did that. And then you decide, no, I want to do additional training in a different area. But I think along the way, for those of you interested in primary care sports, you're going to have to seek out, if you're doing internal medicine residency, you're going to have to seek out those opportunities to you know, build that resume, as Dave said, to make it exceptional. Why is it different? Because of our protocols and restriction on numbers and how many people we could have in the facility. I couldn't even have an associate medical doc with me on the sidelines this year. So I think those opportunities have been tough. And I hope that changes as we go forward. But those skills that I used this year, especially, were as an internist. To understand the pathophys of COVID-19, to understand the cardiac clearance, to understand tracking and tracing. I set up today a nursing home resident who's a family member of a coach that I'm getting monoclonal antibody therapy. That's what being an internist is, but it's about the relationships for me in sports medicine. I think as we went through internal medicine, you worked in the ED, you worked in the ICU, you worked collegially with your surgical subspecialist, with your orthopedist, with your general surgeons, with your transplant surgeons. And it's all about those relationships. You work together to pull in the same direction. And that's what medicine's missing a little bit now. It's not my problem, it's someone else's problem. And I think sports has given us those relationships, that integration with our surgical colleagues, with our athletic trainers, with the athlete, him or herself. So I think that's what attracted us to this subspecialty area of our medical practice.
Fantastic, Dr. Gritter. Thank you very much. And if there's anyone else that would like to have a closing remark. Okay. You guys love solving complex problems. You guys love the athlete aspect of sports medicine, and you've kind of found a way, either if it's down later in your career path like Dr. Gritter, or through like straight out of residency. You guys all found a way. So that's pretty cool. Thanks again for all of you guys for showing. Thanks again for AMSSM, Joan, for setting all this up. Have a great night, and we'll see you next on the next week for our, help me out with this one. It's not internal medicine. What's next week's, Joan?
Pediatrics.
Pediatrics. Thank you. Yes, big P. All right. Have a good night. Thank you very much.
Thanks, everybody.
Good night.
Thanks so much.
Thank you.